Mtazamaji, moja kwa moja basi nataka nikuarifu kwamba mamlaka ya takwimu nchini kwa ushirikiano na Wizara ya Afya inazindua ripoti kuhusu idadi ya watu na afya ya mwaka 2022 KDHS. Aidha, ripoti hiyo ni ya 7 kuzinduliwa na inaangazia masuala yanayofungamana na uchumi, jamii, afya bora kwa wote, utumizi wa mbinu za mpango na wa uzazi na vile lishe. Hebu tuelekee moja kwa moja basi kwenye matukio na hafla ambayo inaendelea kwa sasa hivi ambayo ni ya kirasmi, na tunakuletea matangazo ya moja kwa moja kutoka jumba la kimataifa la KICC.
The only thing is that we are not appreciating them. Thank you. Thank you. And to guide the whole process, we had, other than the KNBS board, we had the steering committee coming from the various public institutions and the development partners. Kindly just rise up to be seen wherever you are. Yes. Thank you. So the two groups have actually made us be here today. And now back to the presentation. Move to the next slide. And move. Yeah, so the primary objective of this study of DHS 2022 was to provide the up-to-date estimates of demographic and health indicators to guide planning, implementation, monitoring and evaluation of population and health-related programs at the national and county level. So we have a number of reports that are speaking to the counties. We are not able to have all of them because, of course, the sample size that would be required to get indicators that are hard to achieve using small sample size. So the tools, we had 5 different tools. 4 of them relate to the survey directly, as given on the screen. The next one. Now, we normally get a lot of comfort from, if you are doing a survey, you need to get comfort from the size of that survey and the distribution of the elements that are giving you the data. And so we had 42,022 households that participated in this. Actually, we selected 42,300, but then we managed to identify 42,022 households. Then those that were occupied is given there. So the percentage that that were able to respond was 98. Then for women it was 95, and for men, as usual, it is low. Men are never found, are not easily found in their households. It was 87. Now then, my presentation is only covering 3 parts: the housing characteristics. Just go to the next one. The housing characteristics, and then the household population. Then the last one is on water, sanitation, and hygiene. Now, this forms the basis upon which the results have been, the data has been analyzed and results given. Now, we had something on the electricity penetration in the country, and we noted that Kenya has 51% of the population having electricity. In the census of 2019, it was 50.4. So in the survey, we have established 51%. And of course, it is higher in the urban and relatively low in the rural. Now, we also looked at the element of the usage of the electricity. Those are using it for cooking, then heating and lighting. And we realized that in the country, 21% is using electricity for cooking, heating, and lighting. But for the lighting, for the urban, it is high at 53% and relatively low at for the rural at 5%. Now, the next one is on the households with information communication technology, and that is by residence. So we are looking at the urban and rural. So in Kenya, we take note that those who are using mobile phones are actually the majority. So you walk into a Kenyan household, one of the things that you'll easily get is a mobile phone, and you can see the percentages. At the national level is 94, in the urban it is 97, and in the rural it is 91. Now the computers, this is the most the most rare one, where we only have 11% of the population of the households is having computers, and majority of them at 22 is in at 21 is in the urban. So that is, and of course that is these are some of the channels that would also be helping us when it comes to getting information. Now, in terms of wealth index, we have what we did was to look at the key household goods and then their numbers, so that we are able to calculate or come up with information on. Let me take a short break as our CS is coming in. Welcome, Madam. Yeah. So the CS, Minister of Health, has just walked in. Madam Nakumicha Wafula, thank you for coming in and attending to this important function. Actually, most of the indicators in this survey are used by the Ministry of Health. And so it is such an important document to the ministry, and you can see the demonstration on that. So then I would continue. So we looked at a number of household goods, and they were assigned scores, and also in terms of numbers and the kind of goods that we have. And out of that, we created the wealth index. And within the wealth index, it was subdivided into 5 to give us the component of various levels of wealth quintile, which is given on the screen there. So we have in the rural, in the urban, the majority of those who are in the highest wealth quintile are 53%, while in the rural, those who are just falling in that category, the highest category, are only 3%. But we also take note of this component in the rural, where the lowest, second, and middle, we have 29, 28, and 26% respectively, and we can see that this house in the rural, majority of them would fall in the lower wealth quintile. Now, the other thing that has been revealed when we look at the wealth quintile in terms of counties, then Turkana County happens to have the highest proportion of the household that are in the poorest quintile. And Nairobi, of course, at 71, is in the highest category of the wealthiest. But notice also need to be taken that much as we are saying they are rich, they might not be really, really rich, but they belong to the higher socioeconomic status beyond the other 80%. So for this one, if you are to draw the graph, you'll be talking of the cumulative graph and subdividing into 4, so that you are clearly able to see what you are talking about in terms of population and where they belong to. Then next is to look at the household population, which again we have just a few indicators to demonstrate what is contained in the big reports. And in terms of population household, we have the 40% of Kenyans of the population being under 15 years of age. That means we have a large group of Kenyans to really plan for, because at that age, and below, we require a lot of resources to support the youth. Then in terms of headship of households, 34% of households are headed by women. In the last DHS of 2014, it was 32, so it has gone up over the period. Then households, the household average, that is the number of people in a household, has been established to be 3.7%. There is no human being who is half or quarter or the like, but that is the average. So it is between 3 and 4 persons being common in household. Now in 2014, we established the number to be 3.9. So that means something is happening to our population. We are actually, we are slowing down in terms of growth. So I'm sure Dr. Sheikh will elaborate on that, because his family planning approach is actually working. It is demonstrated, well demonstrated there. Now, health insurance coverage. This is an issue which is a big concern to the country, and the Kenya Kwanza government is taking it up very, very seriously. We established that, or the survey established that only 26% of the household population had insurance cover. Now, that 26% is now broken down in the next graph on the right. And on that one, what it says is that majority of that group of 26 are actually have taken the National Health Insurance Fund, that is NHIF cover, and that is at 24%. Then we have the private and commercial, which we get from other insurance companies, is 4%. Then we have community-based. Community-based kind of insurance is that people are coming together, the community is coming together to contribute money and get some form of insurance. Or they contribute, but they keep their resources so that when any member falls unwell, then they are able to take care of the medical cover. And so that is, if just go back to that slide. If you try to add them, they'll not come to 26. It is more than 26 because there are multiple cases. There are those guys who have taken NHIF and they are also insured through other means. So that multiplicity means that you are not going to get just the 26%. So the next one is the birth registration. And for the birth registration, we are taking note that we have just about 34% whose births are registered, and then we have 42 where it is registered but the birth certificate is not there. Then we have those cases that have not been registered. So in all, we are talking of 76% whose births are actually registered, and we have 24 without their births being notified and registered. Now, in this case, when you look at the slide, you might think that there's a mistake. It's just a coincidence, mathematical coincidence. We have 24 up there, 42 next, and then 33. There's no mistake in it. It is as correct as presented there. Next, now, as I said, there are a number of slides that are covering the county situation, and so we have presented a few of them. For the counties, we are presenting them using the maps for clarity of seeing what is happening. So that birth registration that we looked at the county level, of course, it is still at 76% at the national level, but at the county level, we see the disparities where the Nyeri County has 96% coverage. That is the highest. And the lowest happens to be Wajir at 30%. So it varies across the board. But our average is 76. Next is the net school attendance ratio. This one is looking at those people who are meant to be in school, those who are meant to be in primary school at the right age, and those who are meant to be in secondary school at the right age. And so it is only looking at the total numbers of those ages against what numbers are really in school. And so we realize that for primary, the net attendance ratio is 86%, while in the urban it is a little bit high at 89%, and of course lower in the rural at 85%. Now for the secondary, it is much lower. Remember, not all are in primary, and not all are joining Form 1. So we have Form 1 up to Form 4. So we have 49% for the secondary case. And in the 2019 census, we actually established 42.4%. So there has been some improvement over time. Next. Now I'm looking at the water, sanitation, and hygiene. And to take us there is the question that was asked about drinking water. Not the general use of water, but drinking water, and it is done by residents. And you are able to see the ladder that is given there. In that ladder, it is saying that about 2/3 of Kenyans, that is 68%, has at least basic drinking water. Now, basic drinking water, when we talk of at least basic drinking water, what it means is that we are looking at water from improved source, and it is either provided within the premises, or if you are to go for it, you'll take not more than 30 minutes to walk there, fetch the water, and come back. Now, that is the at least basic service. Then we have the limited service, where you will be going to get the water, but it takes you more than 30 minutes to get there. More than 30 minutes to walk there, fetch water, and come back. So then we have the unimproved sources, which are a bit now not safe at all. Same to the surface water, which would include the river and the like. So we take note that at the national level, we have 68% for that, urban 91%. So the usage of safe water is much higher in the urban, and only at 56% in the rural. We go to the next slide, which is still on the same, but now breaking it down by counties, and you can see how varied it is. Maintaining the figure at 68% for the national, we realize that Kitui happens to be having a very low percentage of the population who are able to get at least basic service. This is followed by Samburu at 29%, West Pokot at 38%. But then there are those counties that are doing very well. We are able to see that we have Nairobi, of course, being the highest at 99%, followed by Kiambu 94. We have Nyeri 91, and we have Nyandarua at 90. So basically, the central Kenya region, is actually enjoying safer water, drinking water. Then we move to now of the water that we are talking about. How about its availability? Is it sufficient enough for the population? And we realize that at the national level, it is 65%. But we have Vihiga and KICC that are feeling that their drinking water is sufficient at 90%. But Garissa has the lowest at 23%. Then we move to the element of sanitation service, and we are looking at the ladder. I forgot to tell you one thing. As we are looking at these slides, the far right-hand side, if it is an indicator that is also required to be reported for the SDG, we have indicated on the slide that it is which particular indicator. So we are talking of two indicators for this case of the sanitation, and so you keep on checking on the slides. We have given those those details to help us understand that we are reporting quite a number. We are able to get quite a number of indicators within this survey to report for the SDGs. Of course, these slides will also be on our website for you to access. So on this, at the national level, we have 41% of the population having access to to at least basic sanitation services. And here, what we mean by at least basic sanitation service is the use of improved facilities which are not shared. So if you talk of at least basic, then we are talking of an improved facility whose services are not shared by other households. It is only used by one household. Now, limited service is a situation where it is improved facility, but it is shared. It could be shared by by two households or even more. And of course, the other one is not a good one, where it is we have an improved one, then we have the open defecation, and you can see in the urban we have cases that are still using the open at 1%. We have rural 10%. No, is that an open? No. It is 10% is using the open defecation, and that's such a serious concern in the world of today. We move to the next one. I'll jump that one. It is meant for the authorities on what they need to do based on the findings that we have. Just move to the next one. Then it's about the availability of hand washing facility by county. So we at the national level it is 51%. Of course, if it were during the COVID time, if this survey was to be conducted around the COVID time, definitely the percentage was much higher. But I think people have relaxed to a great extent. We only have 51%. Now, so Nairobi has the best, but then Tana River and Wajir are only doing it at 7% each. Then we go to the next slide, which is on menstrual hygiene by residents. Again, this was captured for those for the females who are between age 15 to 49, and at the national level, we note that almost all women have access to clean and private place to change and wash during menstruation time, which is a good thing. But we do not know if you are to bring on board the younger persons. Maybe the situation could be, the percentage could be a bit different. But as it is today, it is better, though you'd want to have it at 100%. Now, all that I've been talking about on that are actually covered, are given in that slide. So maybe if you feel you needed to take a photo of that, you could do that. Otherwise, I don't need to repeat what is there. Now, I'm now looking at the response characteristics, and we are starting with, remember, these characteristics are the ones that are forming basis for analysis. So then, on the education in terms of literacy, we note that 91% of women in Kenya are literate, and 94% of males are literate. So when we talk of literacy, we are looking at women and men who attended school higher than secondary level, and the same women and men who attended, whose school attendance was less than that, but are able to read a whole sentence or part of a sentence. Now, we are able to at least get something from here. It is long since we did the literacy survey in the country. The last one was done in 96, and the gentleman who was actually dealing with it is here, Fred Otieno. I'm happy that you are here, boss. He's the guy who also introduced me to the DHS, and I've kept the fire burning, sir. Thank you. So literacy survey, we need to do it, but as at now, we can be comfortable that Kenya, the Kenyan population is highly literate at 91% for women and 94% for female. Now, the next one is on the mass media exposure. And so here, we are looking at it that access to mass media facilitates information and intellectual growth. And so the percentages that are able to access various forms of getting information are actually given where we have the newspaper, television, radio, and all the three. Then those who are also not able to get any of the three. So we note that the most common one is radio, where for women it is at 62% and men 71%. Newspaper is less accessed at only 8% by women and 17% by men. And of course, in each category, you realize that men are actually having a better chance of accessing these channels. And for the non, you realize that again now women are forming the majority, which is not a very good thing for us. But that is the situation we are in. It is that low for getting those who are accessing it in all the three forms. Now, then the internet usage, in all, men and women use internet, but what we are presenting here is for the last 12 months, and the last part of it, which is 44% and 56%. Again, men use it more than females. So the question was about usage of internet in the last 12 months before the survey. So that is what it gives. Then the next one is employment. And as I said, these are the ones that will be able to help in analyzing the results. So for the health, for the employment status, which is given by age and by sex, we note that 60% of women and 81% of men were employed in the last 12 months before the survey. And employment is higher with both groups past 25 years of age. So you can see it is actually growing higher as you go along. Now, when we talk of employment here, there was a question that was dealing with 7 days. Have you worked for the last 7 days before the survey? And then the other question was about, have you worked, did you work in the last 12 days before, the last 12 months before the survey? And so in that last 12 months, it contains those who are working at one point and maybe they are no longer working, they don't have a job. Those who are working, but for some reason at the time of the survey, they are on leave or sick or something. All of them are included there. That's why they are very high. It does not mean that the Kenyan population has jobs at that rate. Then I'm concluding by an indicator on tobacco, and you can see it is also an SDG indicator 3.8.1. Now here we are dealing with the percentage of women and men aged 15 to 49 who are currently using any type of tobacco. Here we are able to see that men use tobacco more. And by the way, I'm talking of usage, not smoking. Let us get the difference. It will be explained ahead somewhere. Now, we are talking of use. You know, there is the smoking, and there is also putting the tobacco in the mouth. That is usage. That is use, not smoking. But it results into the same thing. So in the survey, we talked of usage, and you can see the figures are rising by age. And that is for both men and women. But for men, it is they are the most notorious one on that, as you can see. So we take note that it is a bit rare in Kenya because it is only 1% of women who are smoking, and 12% of men who are, sorry, not smoking, who are using it, and only 12% of men who are also using tobacco. Now, recently, and very, very recently, I think within the last 1 month, a report was released by NACADA, which was it was 2022 National Survey on status of drugs and substance use. And in it, it established that for persons who are 15 to 65 years, 17 of males were using tobacco, and 2% of female were using tobacco. We have seen the difference. There's a slight difference between the two, but they are actually very, very close. Now, then, when you get to this, this one is also broken by the same thing, but broken down by counties, and we see that in the country it is 10%, 1% for women. But now look at Turkana. Turkana has 33%, and Samburu has 16%, and Marsabit has 10%. That is for women. So the usage is high in Turkana at 33%, while the national average is only 1%. You can see that difference. So it is very common in Turkana. Then the next one, which is for the men, it is 13%. Now, something is not very right. The other one is, the national is 12, and here is 13. Something is not very right. One of them is not correct. We'll be able to have the corrected version as we upload it on our website. Now I cannot tell whether it is 12 or 13, but we'll confirm. Now, the breakdown shows that the northern region is actually highest when it comes to use of tobacco. We have Marsabit 32%, Turkana 27%, Samburu 36%. So we have some areas that are look at the red part. Actually, those are the areas with the highest usage of tobacco. But the Mandera, Wajir, Garissa, Wajir, Garissa, yes, no, Mandera, Wajir, they are actually using it much less. That is northeastern, which is also a good thing. So then I go to the alcohol one, the alcohol consumption, which basically is my last one. This is the last slide I'll be speaking to. 26% of men use alcohol. 5% of women also use alcohol. Highest usage is in urban, as you can see in the middle graph, bar graph. And so if we compare this one with the National Survey on Status of Drugs and Substance Abuse, we noted that for female it was 5%, as also given here, and then for males it was 20%. Of course, those differences, I've mentioned that the national one, the NACADA one, was talking of 15 to 65. And this one is talking of 15 to 49. So those differences in age could also be contributing to the difference that we are seeing. But what I'm trying to confirm to you, that the two are speaking to the same thing. The last slide is just giving the summary of what I had for what I've been talking about. So thank you so much. That is the end of my presentation. My next colleague is actually coming on board. Dr. Sheikh is coming to take us through. In the Bureau, we provide the statistics. After that, we hand it over to those who will now deal with the policy matters. And the gentleman coming after me is dealing with policy on issues of what we have given. And actually, all the speakers who are coming behind me are speaking to the same, dealing with the now matters beyond the release. What will happen? Of course, today they are giving the report, but in the evening, we'll now start talking about how do we make good use of what we have gotten from the survey. Thank you and welcome, Daktari.
Good. Thank you, DG. Thank you very much. So to become a coffee, DG. Our CS for Health, Madam Susan Wafula Nakumicha, the EPS, Madam Catherine Moki, representing the PS for State Department for Economic Planning. Colleagues, ladies and gentlemen, good morning. Good morning. Please say hi to your friend, your neighbor there. Yeah, please. We're doing, this morning is a very bright morning. We're doing this presentation of the Kenya Demographic Health Survey. Mine is just very simple. I'm going to do a deep dive on the demographic and the health data, particularly focusing on issues to do with fertility. We'll start with fertility there, you can see. And I want to report next, please. So we'll be having a presentation on fertility, family planning, maternal and newborn health, and other health indicators. So to start with, on fertility, I just want to, you can see there that graph there, the total fertility rate in Kenya, which is the average number of children a woman will bear in her lifetime, has been declining. You can see from that graph, from 6.7 in 1989 to 3.4. So in terms of population data, this country is doing very well. Our target for 2022 was in fact 3.5. So I think we need to clap for ourselves for achieving that figure. But then the decline, you can see there is the next slide, there is a variations across the country, and you can see the total fertility rate in some counties. The counties with the highest fertility rate are Mandera at 7.7, Wajir 6.8, West Pokot 6.9, and those with the lowest fertility rate are Nairobi City 2.6, Nyamira 2.7, Machakos and Kirinyaga 2.8. You can just see that slide. Up there, you can see the red. Is it the red-orange there? That color of the northern part, where we have the highest fertility rate of 7.7. That's where we were during independence. So I think that's an area we need to focus in terms of our programming. Looking at birth intervals, again, this is a very important indicator in terms of population and demography. The average recommended, or the optimal recommended by WHO is 36 months. And you can see the Kenyan population, I think the average at the moment is around 42 months. And as you can see from that picture there, you can see 40% of women who were interviewed had a birth interval of less than 35 months. This is a very important indicator because for child spacing, it gives us, this is the period of, the mother and the child, the mother can prepare for the next pregnancy. So, but the good thing is that average as a country, we are at 42 months. That's the interval between the last birth, the last pregnancy, this pregnancy and the last pregnancy. So the next slide, please. This again is a teenage pregnancy. Here you can see on issues of teenage pregnancy, some counties have very high teenage pregnancy. And some of these counties are Samburu, 50%, West Pokot, 36%, Marsabit, that is the red color up there. Narok, 28%, Meru, 24%. These are the counties with the highest teenage pregnancy. These are girls or women aged between 15 to 19 years who have ever been pregnant. Well, Nyeri, which is 5%, Nyandarua 5%, Kirinyaga 7%, Muraga 7%, Vihiga 8%, and Nairobi City 8% have the lowest teenage pregnancy. This, again, is a very important indicator in terms of our healthcare services because teenage pregnancy comes with its own risk. The women of that age are not prepared psychologically, physically, and mentally for the pregnancy. So nationally, we're at around 15%. Another indicator here is on pregnancy outcomes. So out of women who were interviewed, 88% have had live birth, and 2% had stillbirth, and around 10% miscarriage, and less than 1% induced abortion. But for us, a figure that we really need to look at is the stillbirth, and the stillbirth is a very important indicator in terms of the quality of healthcare. So 2% of stillbirth really is a worrisome indicator. Next, please. The other one now is current marital status, and you can see that here in terms of family, I think our marital status, we can see there that around 55% of married women are living, are married or living together with their partners, and around 33% are not married. Well, divorced is around 32%, for female and around 8% for male or men. Next, please. So the next is on trends in early sexual intercourse. I think this, again, a very important indicator in terms of exposure to sexual intercourse. And you can see the trend has been declining. From 1989, I think for both sexes, it was 63%, to now 54 for male and 52 for women. So again, this is just to look at in terms of demography, you know, that from the age of 18, when are women or men exposed to sex. So that's, again, a very important indicator. Fertility preference, I think on fertility preference, we can look at that figure again. You can see on fertility preference is that more than 2/3, that's 68% of the women there of current pregnancy is that were wanted, yeah? More than that 68% of the current pregnancy were wanted, then 62% of live births and 60% of stillbirths were wanted then, as were 7% of miscarriage in the 3 years before the survey. Next, please. Difference between wanted and actual fertility rates. You can see this is in terms of fertility, that 2.9 reported that this was planned pregnancy. That is the rate. And 0.5 was mistimed. And then if we look at in terms of demography, then it means our total fertility rate can come down up to 2.9. When we say mistimed, this is a pregnancy where, you know, it was supposed to be. Let's go to the next, please. This is use of family planning. And here you can see use of family planning, any method, is at around 63% for married women and 70% for sexually active women. But very important is the any method, any modern method, which is at 57%. Our target for the FP 2020 was, in fact, 54%. So Kenya has surpassed in terms of these indicators. But very important is, again, which are the highest contraceptive use. You have injectables, implants, and then you have pills and male condoms. So next, please. In terms of trend, you can just see we started from 18% in 1989. That was the family planning, the total contraceptive prevalence, to now 57%. The traditional method has just stagnated there at around 6%. Our target for the FP 2030 is 65%. So around 57 at least, we're doing very well. In terms of source of family planning, generally, our source of family planning, especially for injectables and implants, is from the government facilities. But you can see there, the pills and the condoms are mostly popular and sourced from private facilities. Next, please. If you look at this, is unmet need for family planning. It is 14%. Northern regions, especially Mandera, Marsabit, Isiolo, Turkana, have the lowest, demand for family planning, satisfied by the type of methods they're using. Next, please. Either the grandmother or someone else. So in terms of exposure to family planning, you have seen the exposure to internet that was presented by DG KNDS. Here you can see the main information or exposure to family planning messages is either through friends or peers, radio, television, newspaper, magazine. But for men, the very interesting thing is that it's from radio, and for female, it is mostly from peers and friends. Next, please. So these are the key findings. So if you can just take a shot of that, and then you can go through what I presented. The next, please. So this one is on trends on child mortality. So here I'm going to present 3 indicators. One is going to be under 5 mortality, infant mortality, and neonatal mortality. So under 5 mortality is the probability of dying before the 5th birthday. Infant mortality is the probability of dying before the 1st year, or the 1st birthday. And neonatal mortality is the probability of dying within the 1st month. Look at that graph, how Kenya has, from 115 deaths per 1,000 live births, and that is 203 to 41 deaths per 1,000 live births. That is for under 5. Look at infant mortality. It will just decline from 77 deaths per 1,000 live births to 32 deaths per 1,000 live births. But very interesting is the neonatal mortality, just marginal decline from 22 to 21. That is 22 deaths per 1,000 live births to 21 deaths per 1,000 live births. That is the area we need to focus. And this, again, a proxy indicator for maternal health services. So here, from 22 to 21, I think this is an area that we need to focus, and this is something to do with the quality of health care, that babies are born live, but they're dying in our facilities. Next, please. This is under 5 mortality per county, and you can see some counties of Turkana, Wajir, Homa Bay, down there, I think mostly in the western part of Kenya, where we have high under 5 mortality. Next, please. These are the key findings for under 5 mortality and infant mortality and neonatal mortality. Next. So here is the trends in antenatal care. Very encouraging indicator and very important indicator. You can see there that our antenatal visits, 98% of women who were surveyed received antenatal care from skilled healthcare providers. That's 98%. And more than 66% of them had 4 antenatal visits. But the one which is worrying is that of the first trimester visit. It's only 29% that they're coming for antenatal visit. They're coming for the first ANC visit. They're coming for the 4th antenatal visit. The WHO recommended is at least 4 antenatal visits, but 8 contacts. Is that 29 of them are coming only for the first antenatal visit. That is a figure that we need to improve from 29 probably to 100% if possible. Next, please. This one is again trends in place of birth. You can see here deliveries at home has declined from as high as 52% in 2008 to 11%. And deliveries in health facilities has increased to 88%. I think this is thanks to our Linda Mama program, the free maternity program. I think that's why we have an increase from 65% in the last KDHS to 88% in terms of delivery in health facilities. Next, please. This is skilled delivery assistance by county. So the counties of Mandera there, which one are those are the counties? Garissa, Marsabit, those are the counties with the lowest in terms of skilled but assisted by healthcare providers. And postnatal care in place of delivery is that you can see 78% of total postnatal care. A large percent of the maternal neonatal deaths occur in the first 48 hours after delivery. Thus, prompt postnatal care for both mother and child is always very important. And here you can see the Safe Motherhood recommends that at least the mother and the child should visit the facility or healthcare provider within 48 hours. And you can see the postnatal care at 78% total for the women. Those who have delivered is around 84%, and it's 32% for those who are delivered elsewhere. For the newborn, okay, you have moved. For the newborn, you can see it is 83% for those in total, and 89% health facilities, and those who are delivered in elsewhere is 39%. Next, please. Type of providers for postnatal care. You can see type of providers. Most of them are here: the doctors, nurses, midwives, clinical staff, at 75% for women and 80% for the newborn. Next, please. Male involvement in maternal health care. Again, male involvement is in the broader reproductive health is one of the key really priority programs in Kenya. We want male to participate in the health care of their babies and the mothers. I'm told I'm far from the mic. Apology. So male involvement in maternal health care is very important, and you can see there that 98% of the men who are interviewed reported that their child attended antenatal or ANC visits, and 54% were present during the ANC visits. In terms of delivery, 91% reported their child was born in a health facility, and 67% went with a child mother to the health facility. Again, this is male involvement in family planning and maternal health program. Lastly, ladies and gentlemen, is about the issue of breast cancer and cervical cancer, breast and cervical cancer examination. And here, early detection of cancer is one of the most effective way of improving outcome of cancer treatment. And as you can see from that graphs there that only 14% of women aged 15 to 49 years have been examined or tested for breast cancer, and 17 have been tested for cervical cancer. So I think in general, that is the key demographic data I wanted to share with you, and those are the key findings. Thank you very much. Apology for the sounds. I was not using the mic, I was told. Thank you. Thank you very much.
Thank you, DG. Up next is Dr. Patrick Amoth, Acting DG, Ministry of Health.
Cabinet Secretary for Health, Madam Nahumicha Susan Wafula, the Principal Secretary, State Department of Medical Services, Harry Kuntai, the Chair of the Board of Directors, KNBS, Mr. Stephen Wainaina, the DG of KNBS, McDonald Obudo, the representative of Bill Melinda Gates Foundation, Samburu Washiko, representative of UNICEF, a representative of various development partners, distinguished guests, ladies and gentlemen, good morning. I will take you briefly through some of the other indicators because health and population are closely related. That is why, in the spirit of collective responsibility, Dr. Sheikh dealt with quite a number of indicators that impact population and health. So I will take you through other indicators that were not mentioned, but which are critically important for us to be able to assess our progress as a country in terms of demographic health survey. So that slide is about trends in childhood vaccinations, which is at 80%, fully vaccinated child at 80%. But how we wish that it could be able to have a more sharper upward trajectory so that we don't leave any child behind. If you look at the bottom part of the slide, the number of children who are not vaccinated, the zero-dose children, has stagnated for the past 30 years and is at 2. So it means out of 10 children, 2 of them have never received any vaccine, and therefore providing a serious risk to those, even those who have been vaccinated. Next. This is a hotspot map showing the percentage of children who are fully immunized using the national schedule of immunization. And you can be able to see the deep oranges in the northern arid lands. That basically tells you about the discrepancies or the inequities or disparities in terms of the national average, masking now the challenges that individual counties have to deal with. If you look at Mandera, and therefore the spread is so huge, Mandera at 6%, Tharaka Nithi at 82%, a spread of 76 percentage basis points. Therefore, we need to work concertedly to ensure that those children in northern arid lands are equally reached with these important vaccines. Next. So 80% of children 12 to 23 months are fully vaccinated using the basic antigens, but more important is that out of 10 children, it's only 6 who are fully vaccinated using the standard immunization schedule. Therefore, it means at any given time, if you go to a school or go to a home or a village, out of 10 children, only 6 are fully protected. The 4 who are not fully vaccinated then pose a risk even to those who are vaccinated. And that is why we keep on reporting outbreaks of measles, rotavirus, and other vaccine-preventable diseases. We need to ensure that we reach all our children in line with our journey towards universal health coverage, meaning that we leave no one behind. If you look at growth, which is very critical because we need all our children to be able to achieve their full potential. Stunting, if you look at that figure from 30 years ago, was at 40%. That has come to 18%. We need to be able to drop this further so that our children can be able to achieve their full cognitive potential and contribute to the development of the country. If you look at overweight, because obesity and overweight is the next pandemic, that figure has come down very, very well. It means now that mothers who are taking care of children are providing good nutritional good nutritional services to the children to ensure that the children are within the right weight band. Next. In terms of breastfeeding, and breastfeeding is very important because it's the first immunization the child gets. It is cheap, it is affordable, it is available 24/7. This figure has stagnated at 60%. How we wish this could be able to go up. But more important, if you look at the children who were introduced to solid or semi-solid foods before, within the period of 6 months, that figure is alarmingly high. So we need to be able to promote breastfeeding so that more children can be able to get the right nutrition and get the protection, and also promote infant and mother bonding. Next. This is the nutritional status of women. Again, I told you about obesity and overweight and the concomitant increase in non-communicable diseases. If you look at the women 20 to 49, 45%, 28 plus 17, are either overweight or obese. But if you look at the lower part of the graph, or the lower part of the slide, women, teenagers aged 15 to 19, only 11% of them are overweight, and only 2% of them are obese. The moment they flip over to the 20 years of age, then the figure more than doubles. So we really need to be able to work with our teenagers to inculcate good nutritional habits, good physical exercise habits, so that we can be able to avoid the burden of obesity and overweight. And if you look at the Kenya Health Policy 2014-2030, policy objective number 2 is to be able to halt the rising burden of non-communicable diseases. Non-communicable diseases in our setup are coming much earlier. They require longer periods of treatment. They require more time of the healthcare workers. So if we can be able to make investment in this space in terms of prevention, then we can be able to ensure sustainability of our healthcare financing to be able to provide the entire spectrum of services. Next. So stunting has come to 18%, good progress, but we can be able to do much more so that our children can be able to achieve their full potential and contribute in future to the development of the country. Wasting again has reduced. Children who are under 5, who are underweight have also reduced. Breastfeeding has stagnated at 60%, probably because quite a number of women are entering into workforce and cannot be able to ensure sustained breastfeeding for the 6 months period. We need to be able to support them by including establishing breastfeeding spaces in our places of work to ensure that women can be able to breastfeed exclusively for the first 6 months. Next. Malaria still remains a burden in this country, especially in the Lake Belt region and the coastal belt, contributing significantly to under 5 mortality and also mortality of pregnant mothers. In terms of availability of nets, 54% of the population have an insecticide-treated net. Next. However, availability of the nets and usage is a different thing. Behavior change, in terms of social behavior change. Look at where we were in 2020, Kenya Malaria Indicator Survey. 40% of households had ITNs, and 35% were using the ITNs. And in 2022, that figure had gone up to 50%, but there's a gap there of 7%. Those who have nets and are not using them properly to ensure protection against malaria. So we need to be able to advocate, work with communities to ensure that we deploy the nets properly to ensure protection, especially of children under 5 and pregnant mothers. Next. If you look at, this is a slide showing you the use of nets, insecticide-treated nets, versus the endemicity of malaria, because we classify malaria in this country according to the prevalence. Of course, the Lake Belt having the highest prevalence, and the coastal belt. We have the highland area where we get malaria in epidemics, and the seasonal malaria outbreaks in the in other areas, and low-risk counties, especially the highland counties. And you can be able to see that where endemicity is high, the usage is also equally high. That is what we need to be able to promote to ensure protection of the children. Next. Nearly 54% of the households, more than 25 million Kenyans, at least have one net. And that is good because then we can be able to ensure protection of under 5 children and the pregnant women. Next. HIV, as a country, we have made significant progress in the fight against HIV. In our current the triple 95 targets agreed by the UNAIDS, we are on course. And if you look at the knowledge about HIV, the knowledge is basically the same between men and women. In terms of those who have heard about antiretroviral therapy, the risk of mother-to-child transmission, and those who have ever heard of pre-exposure prophylaxis for HIV/AIDS. Next. Sex and condom use with non-cohabiting partners. This is important because it enables us to be able to design interventions in terms of programs, monitoring how those programs perform. And here you can be able to see that 19% of women and 35% of men had had sex in the last 12 months with a person who was neither their husband, wife, nor lived with them, a non-cohabiting partner. But on the right side, then if you look at condom uses, because that is now a risk factor for spread of HIV and other sexually transmitted infections. But if you look at the right side, look at the precautions taken by the partners. 37% of women, it's like women don't perceive themselves to be at risk of getting HIV and other sexually transmitted infections when they have sex with a non-cohabiting partner compared to men. However, in terms of the approach and the work that we are doing together with the partners, we would want these figures to be at 100% so that that risk is reduced to nearly zero. Next. HIV testing during an antenatal period. Dr. Sheikh shared with you antenatal attendance, which has improved significantly. Again, nearly universal at 94%. And our target, of course, according to the triple 95 targets, is 95%. So 1 percentage basis point below what is required of us. Next. This is comparing testing, general testing between men and women. Again, in this arena, women do better. Ever tested for HIV, women at 85, men at 72. And those who have tested in the last 1 year, women at 47 and men lagging behind at 39. For us to be able to achieve the war and eliminate HIV by 2030, then we need to be able to bring the men to the discussion and ensure that they actually do the right thing, ensuring that they know their status. If their status is confirmed to be positive, then they are put on treatment and they adhere to the treatment. And when they adhere to the treatment, then we can be able to achieve virologic suppression and therefore make it literally impossible for them to be able to transmit. And that applies for both men and women. In terms of male circumcision, again, remember we introduced voluntary male medical circumcision as one of the prongs in the fight against HIV. There are communities traditionally that don't circumcise, especially in the Lake Belt, in Turkana region, and in a small belt in Western among the Teso community. And now circumcision, male circumcision is basically a universal phenomenon. So that has been a wonderful success for this program. Next. Again, knowledge about HIV. And for this one, if you look at, we are looking at people aged 15 to 34. Maybe just focus on the bottom part of the slide. That only 6 out of 10 of people aged 15 to 34 have full knowledge of HIV prevention. And therefore, 4 out of 10 are at risk because they don't have the correct information to ensure their protection of getting HIV. And we have picked this as a ministry, and therefore we are developing interventions to focus primarily on the youth to ensure that they remain, they are not infected they're not infected by HIV going forward. Next. Knowledge about HIV is basically universal, but what is critical is that 59% of young women and 61% of young men aged 15 to 34 had knowledge about HIV prevention. This is now the group that we need to focus on, because this is the future of this country, to ensure that they are not infected. Next. I think that's the last of my slides. I thank you for listening to me. The next part of the presentation will be given by Betty Sungura Nyabuto, the CEO of National Gender Equality Commission. Thank you.
Good morning. Our Cabinet Secretary for Health, Susan Nakumicha, the Chair of the Kenya National Bureau of Statistics, the Board, the DG, Bwana Makobudo. Allow me to ride on the protocol that have already been established and proceed to my presentation. It is a three-part presentation on women empowerment, on gender-based violence, and on female genital mutilation. So I begin. So on employment status by age, this survey looked at married women and men who are employed in the 12 months just before the survey was conducted, and you find we have 98% men who are employed and 67% women. And this data again was spoken to by the DG during his presentation. So you have 67% women still not employed. And then control over women's earnings, we have 96% of married women with cash earnings participate in decision making about how to use their cash. And you can see there, mainly a wife, 55%, a wife and husband jointly towards how they're going to use their cash, 40%, or a mainly husband or partner, 4%. Moving on, the comparison of women and their husbands' earnings, you have less women earning less by 71%, meaning the men earn more. Moving on, ownership of assets by sex. You have 33% of the women who are surveyed owning a house compared to the 45% of the male counterparts. When you come to land, 27% of the women own land compared to 34% of the male counterparts. 29% of women have and use a bank account compared to 39% of their male counterparts. And then 78% females, or the women who are interviewed, on any mobile phone compared to 80% of men. And then a smartphone, those who own a smartphone, 43% women and 49% men. So we can see the disparities in terms of numbers here. And this map shows that 78% of women own mobile phones in Kenya. And I think this is really a progressive number. Of course, it could be rising more to, should be rising more to even 100%. But again, looking at the map, you can see Nairobi County, they are leading with 92%. We have Kiambu, 91%. We have Nyeri, 90%. We have Embu, 87%. And the counties with a low number here, we have Turkana, 50%, and West Pokot, 53%. Of course, down coast, again, we have others. Just going back to that slide, where we have Tana River, 60, and even Kwale, 64. So use of banks or mobile phones. Again here, we have in the urban area, 88% of the women would have and use a bank account or use a mobile phone for financial transactions, M-Pesa, or online banking. So we have 88% in the urban area compared to 93% in the urban area for men. And in the rural area, 73% for the women compared to 75% for the men. So you can see the difference there for rural and urban. For the women, 73, and urban, 88. There's a disparity there. And generally in Kenya, women stand at 79% compared to men at 82% in terms of using a bank account or a mobile phone for financial transactions. Going on, women's participation in decision making, we are standing at 66%, where the women can make decisions around their health care, around household purchases, or even visits to their family or relatives, so at least at 66%. And that's very important because women and decision making is a very pertinent part of women empowerment. I mean, you can imagine for you to, for example, look at your health care and you cannot even make a decision. So that speaks to earlier presentations where we have matters of health care very critical, including protection. Women in Okay, I'll pause there. There is an announcement to be made.
Sorry, Madam Betty, for the interruption. Sorry, as I told you earlier, our chief guest and the CS for Ministry of Health have engagement elsewhere, and they are really they are required elsewhere. They need to go, but then they have found it very, very important that they leave us after doing everything that they were meant to do for us. So, chief guest, Professor Njuguna Ndung'u, the CS, National Treasury and Economic Planning, the CS, Ministry of Health, Madam Nakumicha Wafula, all protocols observed. Ladies and gentlemen, I would request Madam Catherine Mwoki, who is standing in for the PS, the State Department for Economic Planning, to take the program so that she can share a few remarks with you. She's also the Economic Planning Secretary within the same State Department for Economic Planning. She's also a member of the Board of Directors at Kenya National Bureau of Statistics. So, Madam, feel welcome. Share with us so that you can then take us to the next level. Welcome.